Hi guys, Dr. Gillard here. This is going to be a video on how to read an MRI disc with a program called Onis 2.5. Now this is a Windows, a PC program. Doesn't work with Mac. You'd have to get something called Osirix. So you're out of luck if you're a Mac person. I'm also going to do a little anatomy review because you're probably a little rusty on that. And this, let me back up. This is a tape or a video designed for my 8th quarter advanced lumbar differential diagnosis, or I guess it's called lumbar differential diagnosis 2 class. And this is a pretty tough class, very important stuff. Lumbar spine is the number one spine area of chronic pain. So you'll be treating more patients. The majority of your patients will be low back patients. So I take this stuff very seriously. I'll also do anatomy review for you. Now, a note to the general public, this is going to be very deep. I suggest you go read. I did another video on how to read your lumbar MRI, which was a little more watered down, and I take things a little slower. These are for students, 8th quarters getting, they're pretty advanced students, so they know quite a bit of this. It just needs, their memories need to be jogged a little. So I am going to go pretty deep and assume you know a lot of stuff. You're welcome to stay and watch though. And here we go. This is a spine from the back. This is called a P to A view. Thoracic spine, cervical spine, lumbar spine, sacrum. It's like a tower of building blocks. The building blocks are called vertebrae. The vertebrae, just like a tower, has a base, and that's called the sacrum. The sacrum connects to two coxal bones, which make up the pelvis. Basic stuff that you already know. It's made up of 5 lumbar spine. It's made up of 5 lumbar vertebrae. They're separated by an intervertebral disc. We said it sits on top of the sacrum. From the sagittal view, we have a lordotic curve, which is important for biomechanics, right? Normally the axial load, which is the weight pushing down, that goes right through the center of the disc, the nucleus pulposus of the disc. It carries about 80% of the axial load. Facets carry about 20% of the axial load, which is how things are designed. When you lose your lordotic curve, you get biomechanical problems. We'll go over that into the class. A P to A view, spine should be straight. What happens if the coronal Cobb angle is greater than 10 degrees? The coronal Cobb angle. That's called a scoliosis. Notice the axial load. Well, I didn't put an arrow, but axial load pushes down. L5 has more pressure than any other bone. Transfers its load into the sacrum. Sacrum has nowhere to transfer the load to, so it does a 90. The force vectors turn 90 degrees, go through the SI joint, sacroiliac joint, into the coxal bone, into the femurs, and down to the earth. Let's do some parts here in this nice drawing. So what's that? L5 vertebral body. What's that? L4 vertebral body. What's that? I know it's the intervertebral disc. Which one? Whoever sits on top of the disc conquers it. That's L4, so that's its disc. It's conquered it. L4 intervertebral disc. What is a vertebrae disc? Or sorry, vertebra is singular. Vertebrae is plural. Vertebra, disc, vertebra sandwich called? Ah, I got you. Motion segment. This is a motion segment. That's the functional unit of the spine. This is the L3-4 motion segment. What disc is that again? That's the L3 disc. Okay, what's this? L5. L5 sits on the L5. It's not the S1. Some people call it the L5/S1 disc. How about this? Lateral mass of the S1 segment, better known as the ala of the sacrum, this hole. Anterior sacral foramen, very important. Your anterior rami comes out of your S1 anterior ramen. A rami comes out of there. Transverse lines, coccyx. Okay, let's look at a P to A view. What are these holes? That's where your posterior or your dorsal sacral rami come out of. Those are your posterior sacral foramen. How about this? That's your S2 Spinous tubercle or sacrotubercle? Let's stay with lumbar spine though. Transverse process of L3, this thing right here. Superior articular process of L3, this one. Inferior articular process of L2, this space right here. Lamina, this. Spinous process of 5, 4, 3, 2 of L2. Get it? What's this hole right here? Interlaminar space. It's between the lamina. Okay, let's see. I think that's about all we need to see. Lateral view. Is this the right or left neuroforamen, aka intervertebral foramen? It's both of them. We can't tell. It's shot straight through. If this was an X-ray anyway, I mean this would probably be the left one. If it was X-ray, remember X-ray radiographs run these over like with a steamroller and flatten them out so you can't tell. What's this thing right here? Looks like an ear. Well, this is half of the sacroiliac joint. That's your auricular surface of the sacrum. Coming back to you, you should know this like your ABCs. Here's a vertebra. Here's the parts. Made up of two general parts, vertebral body, and it's surrounded by a posterior arch. Vertebral body has, I should have labeled this, but see this little kind of rim? What is that? Not the zygapophyseal joint. Ring apophysis. Ring apophysis. That's where your longitudinal growth occurs in the spine. This is where you grow tall, right through their growth centers in here. So the vertebral body is connected to the posterior arch by these, the strongest piece of the vertebra. Pedicles. Pedicles. Next we have a column of bone called the articular pillar, collectively. Articular pillar is made up of two parts. Superior articular process, inferior articular process. Where they meet is the weakest part of the vertebrae. Good. Pars interarticularis. You can read. That should ring a bell. So fractures of the pars interarticularis can result in what two conditions? Well, what's a fracture of the pars called? Spondylolysis. That means there's no slip. What if the pedicle and vertebral body have slipped forward in relationship to the lower one? Spondylolisthesis. More specific, that type of spondylolisthesis is called a grade, or that's called a type 2A spondylolisthesis. We will learn about that in this class. There's three types of type 2. That's called an isthmic type 2. I can be more specific. An isthmic type 2A spondylolisthesis. Now, superior articular process on the very top has a pad of articular cartilage, has a synovial lining over it, secretes synovial fluid. It meets the one coming from above. This is the superior articular facet of the superior articular process, technically, and it meets the inferior articular process's facet. Together they make up the zygapophyseal joint. Okay, you know that stuff. What else? Let's continue. So now we have, this looks like a kind of a roof, doesn't it? And that's exactly what it is. That's the roof of the vertebral canal. But this is the lamina. There's right and left lamina, or laminae is plural. And that makes up the posterior arch. What does this posterior arch do anyway? It protects the cervical and thoracic spine. It protects the spinal cord. And the lumbar spine, what does it protect? No, there's no spinal cord in the lumbar spine. There's a thecal sac, or aka dural sac, and the nerve roots are not embedded. Remember, in cervical and thoracic spinal cord, the nerve roots are embedded in the substance of the spinal cord. Not true in the lumbar spine. They actually hang like the root. Look, the early anatomists thought it looked like a horse's tail. That's called the Cauda equina. Those are really the traversing nerve roots, as we'll learn. But it's protected by this posterior arch of bone. Okay, the posterior arch, I didn't label it, but you need to know it has a roof. So this is the roof of the posterior arch, is the lamina. The floor of the posterior arch is the vertebral bodies and the disc. All right, And talking about the spinal cord, so here's the lower thoracic spine in this cadaver model, and here's the end. That's where the spinal cord stops, right up here between L1 and L2. What is that called? Let's blow it up. That's the conus medullaris. Remember? So all the spinal cord levels are actually, coccyx is here. L5 is way up here by T12 and T11, L4. That's where the spinal cord levels are. But the nerve roots are super, super long. When you're a little kid, this extends much further down. But you kind of leave it behind when you grow. So this is the Cauda equina. There's a phylum terminale. See it right in the middle, which is a weird little structure. It goes all the way down to the coccyx, anchors itself to the back of the coccyx. What are these things? Well, where's the posterior arch? It's been cut away. Those are the pedicle stubs. So we've pulled the posterior arch right off here. Okay, anything else I want to say about that? This, of course, is super important, right? We've seen this in cadaver lab. That's the sciatic nerve, and it's formed by these anterior rami or ventral rami of L4, L5 form the lumbosacral trunk. S1 also blends into it as well. Oh, that's actually, sorry, oh my God. That's the femoral nerve. That's the big femoral nerve. Lateral femorocutaneous nerve. Medulla paresthetica, if that thing gets compressed there. Remember that from Gross 1 and 2? Femoral nerve is right there. Anterior thigh pain supplies the quadriceps. Here's your sciatic nerve down here. Formed mainly by the lumbosacral trunk, which is L4. See, there's the L4 nerve root coming out right there. There's the spinal nerve, and it splits into anterior and posterior ramus. So this is just showing the anterior rami here, not showing the posterior rami. Okay, got it. And there's S1 coming to join the party. There's a little S2 contributes a bit, but the main ones are L4, L5, and S1. Okay, pretty cool model. Where's the thecal sac? Well, you can see the stub of it right here. It's been cut open. Cerebrospinal fluid's been drained out so we can see what's going on. Sympathetic chain right there. Lumbar spine pain is actually carried within that thing. Okay, here's some important ligaments. So here's a different view. Now this is an A to P view. Here's the front of the vertebral body, transverse processes. And now we've cut the pedicles again, but this time we've removed the vertebral body. Okay, so we can see this is the roof of the vertebral canal we're looking at. So these must be didn't mark them, these are the lamina. So what holds the roof of the vertebral canal together? Very important ligament, especially in people with central spinal stenosis. That's ligamentum flavum, or the yellow ligament. Don't call it that for my class. Ligamentum flavum, though. How about number 2? That's the intertransverse ligament. They're a little bit bigger than this normally. Number 3. Not sure. Look on the other side. Oh, I see. Inferior articular process joint, superior articular process. That's the facet joint capsule right there. That's very important. Synovial fluids inside that. It's an airtight joint. Number 4. That is akin to number 5. Can't see it very good. That's the posterior longitudinal ligament. It's much thinner. Look how broad. This is the anterior longitudinal ligament. So important key ligaments there. Very important view right here now. This is number 1 cause of low back pain is an injury to this darn thing. Injury to this thing is second, close second, but number 1 cause is an injury to the lumbar intervertebral disc. It has 2 parts. Nucleus pulposus. What do the cells of the nucleus pulposus produce? They spit out proteoglycans. Proteoglycans are like SpongeBob. They grab water like crazy, very hydrophilic. So they hang on to water. That's why the nucleus is 80% water. The cells, what's this thing? Must be the annulus fibrosus. Now in reality, there's 2 sections of annulus fibrosis. There's the inner annulus fibrosus and the outer annulus fibrosus. And so the inner annulus fibrosus has more proteoglycan. The outer has more type 2 collagen. But classically for boards, I don't think they'll get that deep. The cells of the annulus fibrosus spit out type 2 collagen. In fact, they arrange orthodromically in these bands that go all the way around the disc. Those are called the lamellae. Make sure you know that, the lamellae of the annulus fibrosus. And they're very strong. And when the axial load pushes down, this would squirt all over the place. But luckily, these lamellae corral it and keep it strong in the middle. And when water's compressed and it can't move, what happens? You physics majors, it becomes rock hard, incompressible. Water's incompressible. So that becomes the pivot point when you turn to the left, when you twist to the right, when you bend. The pivot is right here. 80% of the weight goes through here. 10% on this. What's this thing? It's a Z joint. Another Z joint. So 10% on each side. By the way, this is called the what? This is a column. This is the anterior column, and these are the posterior columns. When you do inner body fusion, you have to fuse the anterior column and the posterior columns. Can't forget about those. And if this is, well, I know this is L5. So this is the L5 disc. How do I know that? These guys right here. We'll talk about those in a minute. But let's do some anatomy. So if this is L5 disc level cut, what's this? L5 pedicle, this. L5 transverse process, this. Careful. That's coming up from beneath. That's the S1 superior articular process. Everything else is L5, lamina, inferior articular process, spinous process cut off. Okay, and this hole is the vertebral canal with the, what's this thing? It's not the spinal cord. That's the thecal sac. Thecal sac. It's like the thecal sac goes all the way up to the occiput, the foramen magnum, but it's very narrow in the cervical and thoracic spine. It's huge in the lumbar spine. And so I didn't draw this, but well, first of all, what if this is the thecal sac, aka dural sac? What's this yellow? Dura mater. Dura mater. What's right underneath it? It's so thin you can't even see it. Arachnoid mater. So this whole black area must be the subarachnoid space. Where's the pia mater? It's around these. These are the traversing nerve roots. This is overhead, a cross-section view. So these are the traversing nerve roots of the cauda equina. Right? Horse's tail. And they often line up really nicely like this because they have to bud. They have to come out to do their job. They're hanging out here having a good time being bathed in cerebral spinal fluid, which brings them food and takes away their waste. But when it's their time to work, they come up to the corners here and they actually rip right through. Well, they don't rip, but they bud off. And so at L5, in a disc level cut, in fact, the traversing roots are already out. I don't know if we talked about that. I better talk about that. Let's talk about the players here. So behind the disc, there are 4 sets of nerve roots. There are the exiting nerve roots, which in this, I drew it in a cartoon. Really, in an MRI, you would just see a piece of it, like you're seeing a piece of this. So there's the exiting nerve roots. If this is L5, this is the exiting L5 nerve root. It's crucial that you understand this. You'll fail the class if you don't understand this, because pathology deals with compressing these different roots. And these are the S1 traversing nerve roots. Traversing, meaning they're going to go down a little bit. They're going to turn the corner and look just like this, down lower. Okay, so if these are S1, who are these? These are S2, S3, S4, S5. Get the deal? Okay, now the disc, number one source of chronic low back pain. What's chronic? Anything greater than 3 months in this country. The rest of the world uses anything greater than 6 months. So These are the sinovertebral nerves. They have a very high density in the back of the disc, especially in this corner here. Now, everything is great and wonderful, and they have nociceptive fiber in them. They're pain fiber. If these get irritated, they can send pain messages all the way up to the brain. So what happens typically is this disc rips open, and you get a rip in this disc. The nucleus squeezes out, gets into here, and irritates these things. Nucleus pulposus, usually when this is called an annular tear, a grade 3 annular tear, is a rip all the way through the disc, also called a full thickness annular tear. But black disc or degenerative disc on T2 weighted imaging, the cells, when they're dying, they secrete cytokines like crazy, especially one called tumor necrosis factor alpha. And that's like gasoline. It's like pouring gasoline on here. And it can cause horrible pain. Sometimes you have to decompress the disc with a fusion. Now, some people have these annular tears, they have no pain at all. Want to win a Nobel Prize, figure out why some people react and some people don't. It's got to be something with your own unique immune system. I'll tell you some theories when we get in class. But these are the sinovertebral nerves. They carry the sensation of pain from the disc. Where do they carry it? Here's the main sinovertebral nerve root here. About 10% of it or so dumps into the sensory division here of the spinal nerve and goes up to the brain that way. That's right, only about 10%. The rest of it, we found this out back in the 90s, radioactive tracer studies. The rest of it goes down the gray ramus communicantes, dumps in to the lumbar sympathetic ganglia, and then, weird as it may sound, it goes up the sympathetic chain to the L2 lumbar sympathetic ganglia. And then, let's pretend we're up at L2 now. Then the pain goes back this way down the gray ramus. It doesn't go down, remember, white ramus is up there too. It doesn't go down the white ramus. It goes down the gray ramus communicantes, and then it dumps in to the ventral root, and then it goes to the spinal nerve through the dorsal root ganglia, and then it goes up, ends up in the sensory cortex of the brain, and your brain goes, ouch, I have pain. So very strange route with pain. Okay, I think that's everything I wanted to say there. Now the other thing you probably don't know, these sinovertebral nerves are also connected to the anterior part of the thecal sac. So that's innervated. If you get a big disc bulge irritating the front of compressing maybe it's not touching either one of these. The low back pain could come because of an irritation of the anterior portion of the thecal sac as well. Here's the budding concept again. So this is the L4 vertebrae. The pedicles have been cut, the posterior arch removed. So notice how the L4 nerve roots bud out of the thecal sac. They poke right out, and it always occurs, almost always, L1 through L4, behind the vertebral body, right between the pedicles. Very bad spot to get a fragment of disc herniation here. Incredibly painful. All right. So this would be the traversing root is inside. Once it buds out, it becomes the exiting nerve root. It's L4 all the way. So most common place for disc herniation occurs in this paracentral zone here. Typically doesn't affect its own nerve. So an L4 disc herniation won't get the L4 exiting nerve. It gets the L5 traversing nerve. Here's the L5 traversing roots, sensory and motor. And herniation would occur right in the back of this thing, and it compresses it right through the thecal sac. So an L4 disc herniation compresses the traversing L5 nerve root. Got it? The only difference is, like that picture I just showed you, look at this weird S1 root. L5 comes out behind between the pedicles like normal. S1 comes out right below it. So you got a double budding behind the vertebral body of L5. Terrible to get a sequestered fragment in here. Can cause horrible pain. Can wreck both of these nerve roots. Okay? So on the MRI, it would appear out. It would appear outside. If I put a cut right through the disc here, if I take a knife and cut right through here, it would be out of the disc. Just like this. Sometimes, look at this person, L5. This one is out and this one is in. So this guy, his L5 traversing roots are actually, they're already, this one's out and this one's still in the protection of the thecal sac. Okay. Here's just another budding. So if this is, the budding has occurred behind the L2 vertebral body, see it budding right out here? This must be the L2, and now it's the traversing nerve root, or now it's the exiting nerve root. Now, I should back up, because some sources don't call it, even though it's budded here, it's still called the traversing nerve root. So if I have a cut going right through here, it's still traversing nerve root really until it hits the pedicle and starts wrapping around the pedicle. But for our purposes, if it's out, we'll call it the, no, we'll call it the, you can really go either way with that. We'll call it the exiting nerve root when we see it. I'll show you an MRI image. When we see it out here, we'll call it the exiting. We'll call both of these traversing nerve roots. Even though this one's budded, it hasn't wrapped around the pedicle yet. So this is still the traversing nerve root. Super, look at that, 4 stars. So you will fail the class if you don't understand this. These are herniation zones. So right in the middle, we have a central zone. Most important zone is right here called the lateral recess or the paracentral zone or subarticular zone. Paracentral and lateral recess are used all the time. Subarticular is not used as often, but you'll see it in a radiology report. You need to know what it is. This is inside the intervertebral frame, and this could have went a little bit farther actually. Pink probably goes up to about here. It should all be pink, and then orange would be anything out there. So that's the foraminal zone. Far lateral zone is out here in orange, or extraforaminal zone. Okay, now look what I'm going to teach you this on the MRI for real, but we'll cheat a little. So what's this stuff? This white stuff is a T2 weighted image. Nucleus pulposus. Annulus fibrosus is in black. So where's our 4? Well, these are kind of covered, but we can see 2. Let's do this one. This is the L4 disc. Who's that? That's the L4 exiting root, just a piece of it. Remember I told you we see pieces. We don't see like I drew in the cartoons. Now here's the thecal sac. You can see it coming around like this. Very hard to see. I can see because it's wider. So what's this? This is L4. This is the traversing L5 nerve root. Here's the other one over here. In fact, this is a T3 weighted image. It's very high quality. You can even see 3 components of this nerve root, maybe 2 motors and a sensory. It's not all. Here's 2 components, motor and a sensory. If you look closely, you can see the root around it. You can see the nerve root. Within the nerve root, these are the 2 components. Very important. And remember S1, a little bit different. There's the sacral, S1, sacral intervertebral foramen. And it dumps into these these anterior and posterior sacral foramen. So when the nerve comes down and splits into its dorsal and ventral rami, they're actually still inside the substance of the sacrum. So that's some weird anatomy. That's not true for L5, right? When it comes out of the IVF, it splits in dorsal and ventral rami. They're flapping in the wind. They don't have a bony protection like that does. Here's the epidural venous plexus, very important when we talk about stenosis. The nerve roots have radicular arteries and nerves in them, and just like living tissue, the cells make waste products, especially when you're exercising and walking, and that needs to be cleared. It's acidic, right? You got to get it out. What happens if these all get compressed by spinal stenosis? You can't empty your nerve roots, and it can cause what's called NIC, neurogenic intermittent claudication. So we'll talk about this. Is important to realize. Hans venous cleft would be right here in the middle. Do I have another picture? No, I don't. Facet joint again. So this is the quiz you see if you remember anything. L3 inferior articular process, all this, L4 superior articular process. Together, those facets come together to form the zygapophyseal L3/4 left zygapophyseal joint. And in reality, it has a capsule around it filled with synovial fluid, innervated by the who, not the band, the who. Who innervates that? Medial branch, the posterior ramus, right? Better look at that. You better know this cold. So let's go through L2. So L2 spinal nerve is right here. It splits into an anterior ramus, aka anterior primary ramus, and a posterior ramus. Anterior ramus goes to form the major nerves that go down the leg, like this would be going to the femoral nerve. Okay. The posterior ramus is a little trickier. It splits almost immediately as well into a lateral branch. So this is coming out of the plane of the page. See the transverse process here? And then the lateral branch can sometimes have a medial or intermediate branch, and these supply the erector spinae muscles, the iliocostalis lumborum, longissimus thoracis. Remember those guys? And then we have the medial branch. This is important nerve here, really important. Notice the L2 medial branch. It supplies its own facet joint. This is where you injure your facet joint. Pain travels right down this wire back up to the brain. So it supplies its own L2, L3 facet joint. It also supplies the facet joint below, part of it. So it supplies the L3, L4. Classic question. The L3 or the L2 medial branch of the posterior ramus supplies what facet joint or joints? It supplies the L2, L3, and the L3, L4. See how that works? Make sure you know that. It's important. Why is that important? Well, what if you're going to have a fusion, and the surgeon wants to know if are you going to fuse the L2, 3 together? Do you need to fuse the L3, 4 together to test it? Because maybe this facet joint is so bad you can't stand the pain. You have to fuse it so it stops moving. Well, the injectionist has to do a intra-articular block where they put the needle into the facet joint, fill it with lidocaine, which is an anesthetic, see if it knocks out the pain. If it does, great. You don't have to. This is the only one they have to fuse. If it knocks out half of the pain, you go down to do this joint. And if it knocks off half the pain, then you have to fuse both of them. But make sure the injectionist doesn't inject the lidocaine here at the base of the medial branch here. Why? Because if it knocks out the pain, how do you know if it's coming from here or here? You don't know which one's the problem. You certainly don't want to do a double level fusion when only a single level fusion is necessary. Chances of recovery are not nearly as good for a double level fusion as they are a single level fusion. See how anatomy is important? There's that venous plexus again. There's the Hans venous cleft there. What nerve supplies the vertebral end plate? I should have put that in there. Can that be a source of pain? It absolutely can be. We'll talk about isolated disc reabsorption. That's the basivertebral nerve, and there's an artery and vein. Those are the ones that go through the Hans venous clefts or the Hans clefts here. Talk about that. Okay, we're done. There's your anatomy review. Let's take a look at what a real MRI, my MRI actually, a 2011 MRI. I'll teach you how to work these things. Okay, see you in the next video.